So yes, today I'm going to be talking about the reproductive potential of low mosaic embryos. I have about 15 minutes, which I'm sure I could spend hours on this topic. So I'm happy to connect afterwards if you want to continue the conversation. I'm just going to start with a brief overview on mosaic embryos, followed by focusing on a publication from last year and how that publication, as well as other recent papers, has changed the interpretation at Igenomix of mosaic results. So to dive right in, I want to start with just reviewing some basic definitions that are likely very familiar to you, starting with euploid. Euploid embryos are embryos where the cells have two sets of every chromosomes. Aneuploid embryos are embryos where the cells have an extra or missing copy of a chromosome or multiple chromosomes. And then a mosaic embryo is an embryo that has more than one chromosomally distinct cell line. In this image here, you'll see depicted both euploid and aneuploid cells. As you well know, with PGTA, a biopsy is taken from the trophectoderm, and that biopsy is expected to represent the whole embryo, thus allowing patients and providers to have information on the reproductive potential of that embryo. Something that's important to point out is when performing PGTA, we're not analyzing each cell in that biopsy individually. Rather, the DNA from those cells is pooled and analyzed as a whole utilizing next-generation sequencing, or NGS. So what is generated is an NGS profile where the sequencing reads align to specific chromosomes and are plotted on a histogram as depicted in this slide. So the flat line that is generated is normalized to a copy number value of 2, and what's assessed for it is any elevations or reductions based on that baseline. The first image here is an example of a euploid profile where you can see the flat line aligns to the specific chromosomes and is normalized to a copy number value of 2, except for when you get to the sex chromosomes, you can see X and Y have a copy number value of 1. So this profile would be consistent with a euploid embryo with male sex chromosomes. Now, when it comes to an aneuploid NGS profile, what is seen as a complete copy number change. So a complete copy number change to a level of 3 would be consistent with trisomy, and complete copy number change to a level of 1 would be consistent with monosomy. So in this example here, you see a complete copy number change to a level of 1 for chromosome 2. So this profile would be consistent with monosomy 2. And then for a mosaic NGS profile, what is seen is intermediate copy number variation. So the reads align somewhere between a level of 2 and 3 or a level of 2 and 1. Specifically in this example, you'll see an intermediate copy number variation for chromosome 3, specifically an intermediate copy number loss. So the third image on the slide would be consistent with mosaic monosomy 3. So now going back to those previous definitions and coming at them from an NGS perspective, a euploid result is consistent with us seeing no copy number change from that baseline, which again is set at a copy number value of 2 in the NGS profile. An aneuploid result would be a complete copy number change in a single or multiple chromosomes, and then a mosaic result would be seeing an intermediate copy number variation for a single or multiple chromosomes. So the calling of embryos as euploid, aneuploid, and mosaic depends on certain thresholds. And these thresholds can differ between different PGT labs as well as through different studies. So that's just something important to always keep in mind. On this slide, I'm highlighting the calling and thresholds utilized at Igenomix clinically. So Igenomix has 2 reporting options: full mosaic reporting and no mosaic reporting. For full mosaic reporting, an embryo would be reported as euploid if the copy number variation is below the threshold of 30%. An embryo would be reported as aneuploid if that copy number variation is above 70%, and reported as mosaic if that copy number variation is between 30 and 70%. More specifically, it would be classified as low mosaic if that copy number variation for that chromosome is between 30 and 50, or high mosaic if that copy number variation for that chromosome is between 50 and 70%. Something that's really important to point out is that we used to counsel on low and high mosaic embryos quite similarly. However, based on recent data, some of which I'm going to talk about in a moment, we're now counseling that low mosaic embryos have significant reproductive potential that is similar to or maybe even equivalent to euploid embryos. Whereas for high mosaic embryos, we're still counseling that they do have reduced reproductive potential. So knowing that has really factored into our threshold used for our non-mosaic reporting clinics. So the threshold for non-mosaic reporting clinics would be 50%. So where embryos show a copy number variation below 50%, they would be classified as euploid, and above that 50% threshold would be classified as aneuploid. Okay, so now I'm going to spend a moment talking about a large publication that came out last year by Anthony Capalbo and colleagues out of Igenomix, Italy. What was performed was a prospective non-selection clinical trial, and there were three major components to this study. The first was retrospectively analyzing the rates of mosaic categories from 6,766 clinical PGTA tests performed. The distribution of results is shown on the left side of my slide with this pie graph. I really want to highlight that the categorization of the mosaic embryos within this study differs from the categorization utilized by Igenomix clinically. Specifically, I want to draw your attention to the yellow slice of the pie chart, which with the study was classified as a low mosaic result with that 20 to 30% threshold. Clinically at Igenomix, these would actually be classified as euploid, as discussed on the previous slide. And then within the study, embryos within the medium mosaic category were embryos had chromosomes with a copy number variation between 30 and 50%. And so those would be what we call clinically low mosaic. So just to stress that point one more time, the embryos that are falling within this orange medium mosaic category in this study are comparable to the embryos that we report out as low mosaic for full mosaic reporting clinics at Igenomix. Something else just to highlight is that the mosaicism rate in the study was 18.7%, which is much higher than what we would quote clinically, which makes complete sense given that the embryos that fall within this yellow low mosaic category in the study would actually be classified as euploid based on Igenomix clinical reporting. A second component of the study was a concordance study that was done using 73 donated blastocyst embryos, specifically analyzing the concordance rate between 4 trophectoderm biopsies and an inner cell mass. So I want to take a moment just to orient you to this heat map, as I know it's a lot of information to digest. So on the left-hand side, you'll see the result for the reference trophectoderm biopsy. So one of the 4 biopsies was referred to as the reference biopsy. And then on the bottom of the heat map, you'll see the outcomes of the other trophectoderm biopsies, specifically how many of them were aneuploid. And then if you look at the top of the heat map, you'll see on the left-hand side is a normal ICM or inner cell mass, and on the right side is an abnormal or aneuploid inner cell mass. So some key takeaways from this. So for embryos that the reference trophectoderm biopsy was reported to have a chromosome within the copy number variation range of 30 to 50%, 95.5% of those had a euploid inner cell mass, and all subsequent trophectoderm biopsies were also euploid. Greater than 99% of embryos that had a chromosome with a copy number variation below 30% had a euploid inner cell mass, and all subsequent trophectoderm biopsies were also euploid. Now to take you to the other corner of the map, embryos that the reference trophectoderm biopsy fell within that high mosaic range of 50 to 70%, 65% of them had an aneuploid inner cell mass, and all subsequent trophectoderm biopsies were also aneuploid. I want to pause there for a moment just to highlight the difference between what we're seeing in terms of the makeup of the inner cell mass between an embryo that has a copy number variation or a chromosome with a copy number variation below 50% versus above 50%. So this really does support that threshold cutoff that's being utilized for the non-mosaic reporting clinics. And then just the last point to make is that for embryos where the reference trophectoderm biopsy was aneuploid, 98% of them also had an aneuploid inner cell mass, and all subsequent trophectoderm biopsies were also aneuploid. Okay. So lastly, the third and probably the most important component of this study describes a non-selection clinical trial that evaluated the reproductive outcomes of embryos classified as mosaic under that 50% threshold. 897 single embryo transfers took place across 5 IVF centers. The embryos were blindly allocated in 3 main categories. Group A being euploid, Group B being low mosaic, and Group C being medium mosaic. Not to belabor the point, but just to point out once again that Group A and Group B within the study would clinically be classified as euploid, and embryos that fall within that Group C category would clinically have been reported as low mosaic at Igenomix. So it's really that Group C category that we're focusing on right now. So on this side, it is quite striking when you look at the clinical outcome data. So looking across a positive pregnancy test, biochemical pregnancy loss, miscarriage rates, and live birth rates, you can see quite clearly that the 3 studied groups have very similar outcomes. There was no statistically significant difference between the outcomes across, again, those 3 categories. So it really highlights that these embryos that are falling within that 30 to 50% range, or have copy number variation within that range, do have, at least in this study, equivalent reproductive outcome compared to euploid embryos. So it's a quite significant and striking image if you look at it. So the big question, should we be transferring mosaic embryos? And I would argue yes, or at least providing patients with the option to do so. And I would add a caveat is yes, with good counseling. I know a lot of IVF centers may not have genetic counselors on staff, but good news, Igenomix has 13 certified genetic counselors on staff that does both pre and post-test genetic counseling. And I can say probably our majority of our patients that come to us for post-test counseling are patients with mosaic results that better want to understand what that means exactly, and if that one or a few embryos may be an option for them. And so, the old argument of, well, we don't have enough evidence to understand the clinical implications of a mosaic result, that doesn't really apply anymore. Some clinics are still electing not to report out mosaicism, but that's more from an approach that these results can be challenging in terms of the interpretation and management of them, but not because there's not sufficient data. One thing that I would be remiss to not point out, and it's probably, I would say anecdotally, the most common question I get from patients about their mosaic embryo is, well, what's the chance of persisting mosaicism? So it's important to point out that there have been case reports of persisting mosaicism with variable outcomes. I'll say currently how we're counseling is that primarily there's a binary outcome after a mosaic embryo transfer. Either that embryo fails to implant or miscarries, or results in a seemingly healthy pregnancy or live born. But it's important to mention that the risk of persisting mosaicism is not 0, and it has been reported. We would quote that risk as less than 1%. To date, there's been over 2,700 mosaic embryo transfers that have been at least reported in the literature, so probably a lot more than that. And what we have currently is about 6 case reports of persisting mosaicism in pregnancy or live born, and again, those having variable outcomes. So in order to provide patients comprehensive counseling so they can truly make an informed decision for themselves, we do mention that the risk of persisting mosaicism, while less than 1%, is still something to consider. Kind of on the other side of the coin, another question we sometimes get from providers is, well, should we even be reporting mosaicism at this point? Is there any value in that information? And again, I would answer that question with yes. We do have robust literature that it aids in our interpretation of mosaic results. Like I said in the previous slide, there are case reports of persisting mosaicism. Furthermore, high mosaic embryos should not be lumped into the aneuploid category for full mosaic reporting clinics because they are 2 distinct categories as supported by the PGDIS statement from last year. And with mosaic reporting, you're allowing for transparency for your patients and allowing them to have the information to make a decision for themselves that best fits their future reproductive plans. And like I said, there are genetic counseling services available. So it's not on the physician or the nurses at an IVF center to counsel on this information alone. We have resources available, and we can sit with patients and really help them understand what mosaicism is, what that means, and what the potential reproductive outcome are for these embryos. So just to conclude, as I mentioned in the very beginning of the talk, Anthony Capalbo's paper, as well as several other publications, has really led Igenomix to adjust their interpretation of full Mosaic or of Mosaic results. So publications such as Viati and, like I mentioned, the PGDIS position statement last year are all information that really has led us to this decision. And so on our PGTA reports, as highlighted on the right-hand side of this slide, you'll see different adjustments that have been made. So now stating that low mosaic embryos have significant reproductive potential, and a low mosaic result is most likely to be concordant with a euploid inner cell mass. And then the risk for high or low mosaicism to persist through pregnancy or to birth is reported to be low. And within the interpretation section, we do include the citations of these papers that I've been mentioning, and that way both physicians and patients alike can have access to these papers to understand where this data is coming from. So like I said, I could talk for hours on this topic, but I'm just dipping my toe in. So thank you so much for staying with me. And if you have additional questions, I'd be happy to connect. And I've also provided the contact information for our genetic counseling department at Igenomix.